in transplant at NHS Blood and Transplant previously, as a lead nurse for enhanced recovery in transplant at Newcastle Freeman Hospital. She coordinated multidisciplinary team to implement ERAS protocols for kidney transplant patients. This initiative led to a 50% reduction in the hospital stays, decreasing the average from 12 to 6 days, and significantly improved patients' outcomes. Under her leadership, the program received national recognition, including Q Factor Award for the quality improvement. Carrie continues to advance ERAS practices across UK, aiming to enhance recovery protocols for various organ transplants. So, Carrie, go ahead. You have 15 minutes time. Please stick to the time. Thank you.
Thank you. Thanks very much. I'm really privileged to be here to talk to you all today. So I'm going to talk to you, just give you a little bit of background about enhanced recovery, talk to you about the programme that we implemented in kidney transplantation in Newcastle, and then touch a little bit about what I'm doing now in our national project. So many of you will be aware that enhanced recovery after surgery, or ERAS, is a multimodal pathway that's known to help improve the patient's recovery around the time of transplantation. It's recognised to reduce the stress associated with surgery. It's very much patient-centred. It encourages patient engagement and autonomy. It reduces the risk of potential post-operative complications, makes better use of resources, and of course reduces the length of hospital stay. And this is something that's well established in many surgical specialties. It's not a new concept, and it's been around since the 90s. Started off in colorectal surgery, and it's really business as usual and mainstay in many realms of surgery. But transplantation, it's been a little bit slower to take up. We heard yesterday that Chennai is leading the way in liver transplantation, and there'll be centres around the world that are taking up enhanced recovery. But certainly in the UK, it's been slow to be taken up. And in Newcastle, we wanted to address that. There is emerging evidence, though, now, more and more, particularly in kidney transplantation, also now in liver transplantation, and also interest in the pancreas transplant community as well. So in Newcastle, we wanted to implement ERAS, and one of the driving factors, although there were a few, was our length of stay at that time. And actually, we were behind the curve, really, in that this is the UK data at that time back in 2019. And you can see we had the longest length of stay for our recipients of kidney transplantation. And we wanted to address that, and we wanted to improve patient care. So we implemented a programme. We created an ERAS protocol. We created documents to support that, to support both the patients and the staff. And we implemented that back in 2021. And this is what the pathway looks like for those patients. So these are some of the key elements of enhanced recovery. So the first thing being patient engagement and preparedness, and one that I would say is possibly one of the most important in terms of managing patient expectations, introducing them to the principles of enhanced recovery, encouraging the patient to take part in their own journey and take some control of their progress and recovery. We used a patient journal that we created, which gave patients an idea of what to expect each day, what sort of things would be happening, and how they could monitor their progress and be involved in their transplant journey. Optimisation of fluids is clearly a key element with this cohort of patients. And in Newcastle at that time, we certainly were guilty of drowning our patients a little bit in fluid and giving them a lot of fluid. And so we tried to devise a protocol that would reduce the amount of fluid we were giving to our patients, making sure they were well hydrated still, but not overfilled, with earlier discontinuation of intravenous fluids, starting diet and fluids at an earlier stage, and capping the amount of fluids they were encouraged to drink each day. We created an opioid-sparing regime for pain relief so that we could reduce the burden of opioids. We introduced some transabdominous plane catheters for this, which provided a local anaesthetic around the kidney, and that enabled us to reduce the amount of opioids patients were having. We created a bespoke mobility programme for patients with the physiotherapists, giving patients daily targets to get up and get moving, and supporting them to know how to do that and how to continue their progress following discharge. We also created a protocol for our drains and catheters. So it differs in the UK, and some centres were already not using drains at all, but we were using 2 suction drains at the time. So we created a protocol to aim for 1 drain or no drains if the surgical field allowed. We also wanted to aim for a more proactive drain removal at an earlier stage and an earlier catheter removal as well. And importantly, patient education and follow-up as well. So target days for certain elements of patient education around medications, around looking after their transplant, and support so that they knew how to look after themselves at home, how to continue their rehabilitation. So we implemented this, and this is the results for the first 200 patients that we did in Newcastle. You can see where we were back in 2019 with a length of stay of 12 days. Around the time of COVID, we did have a bit of a drive to try and discharge patients a little bit earlier, but they were a very small number of patients. Then we started our ERAS program with the pilot phase, and then where we are now is a length of stay of 6 days, so half what it was originally. And you can see that worked for both the recipients of living donors and recipients of deceased donors as well. And we didn't see any increase in intensive care admissions or any hospital readmission rates that you might expect. In terms of fluids, we reduced our median fluid volume. So you can see we were still giving quite reasonable volumes of fluid, 2 litres, but prior to that, it was around about 4 litres we were giving patients. We managed to discontinue our intravenous fluids at a much earlier stage, within 24 hours for the majority of patients, but you can see actually around 13 hours was the median. And this nicely demonstrates the confidence of nursing staff that with the protocol, rather than having to wait for the ward round and wait for the doctors to come around and decide whether to discontinue intravenous fluids, they could be autonomous and they could make a decision based on certain parameters and take that fluid down earlier so that we weren't waiting, and that was really successful. With our transverse abdominis plane catheters, we put them into the majority of our patients, and as I said, that enabled us to reduce the amount of opioid burden by discontinuing the fentanyl PCAs that we used. And you can see the reduction there before ERAS and after ERAS, a significant reduction in fentanyl use. And as you might expect, on the right-hand side there, you can see with post-operative nausea scores, we didn't really make much of a difference to the severe or moderate nausea, but where there was mild nausea, it's virtually disappeared with the changes to our protocol. With our mobility, this was a really important element, and you can see that by putting in this sort of 7-day physio and this ERAS mobility program, that prior to this, we had about half of our patients that regained their level of pre-transplant mobility by the time they were discharged, and that went up to over 80% with the program. And again, in terms of how long it was taking patients to gain independence, that was around about 4 days initially, and then it went to just over 2.5 days. And with our drains and catheters, remember I said we were using 2 suction drains at the time in Newcastle, and we had generally a day 5 removal. We changed that to 1 single drain in the majority of cases, and actually in 9% of cases no drains, and that percentage is happily now increasing all the time as surgeons are feeling more and more confident not to put drains in. And we went to a median of day 3 on removal. With our catheters, again, we were originally taking catheters out generally on day 5, and we went to a median of day 3, and then following the success of that, we were able to extend that further, and we now take catheters out on day 2. And we didn't see an increase in the incidence of collections that required drainage, and we didn't have any anastomotic leaks either. We did survey our patients and our staff, and we had really good results from that, and patients feeling empowered, supported, feeling that it took away some of their anxiety because they were better prepared and knew what to expect, and staff echoing that, saying that they felt that patients were taking more of responsibility of their own care and getting involved, and also staff and nursing staff particularly feeling autonomous and being able to make decisions based on their own experience and level of competence, which was great. We also were fortunate enough to win a couple of local awards as well, which was great, and that really boosted staff morale. And so it was a really successful programme overall. And so I've now left the Freeman Hospital in Newcastle, and I've now joined NHS Blood and Transplant, which is a national organisation. And what we're trying to do is to take these enhanced recovery principles and really encourage and facilitate the uptake of enhanced recovery across the UK. And we're doing this by drawing from existing best practice that's already out there. There are some centres that are already implementing it, and just interested experts in transplantation. What we're wanting to do is trying to create some guidance for teams to say what enhanced recovery looks like in kidney transplantation, and provide a repository of evidence-based resources to support centres to adopt ERAS. And we started with kidney transplant because that's where most of the evidence was and most of the experience was at that time. But there's of course scope to include all other organs, and we're working our way through that at the moment. And we're trying to use a model that will be replicable in each of the organ settings. And it's a key deliverable for us at NHSBT. This is, so what we've done so far is we've published now our kidney transplant ERAS program, and this is a snapshot. I wasn't sure what the Wi-Fi would be like, so I've just taken some snapshots of our website, but this is, you can go out there and see this on our NHS Blood and Transplant website. So you can go to the homepage and it tells you about enhanced recovery after surgery and what it is, and then there are specific guidelines for each organ group, and we hope that we'll replicate this with the different organs. At the moment we just have the kidney transplant guidelines published, and you can see that here you've got the kidney transplant recipient pathway, and we've split the pathway into pre, peri and post-operative areas, and then under those sections you have key areas, so preoperative education and counselling, prehabilitation, perioperative phases, post-operative phases, and under each of these sections you have, for example, if we take preoperative education and counselling, you have core elements, so suggested key areas of enhanced recovery that should be classed as core, and then some desirable elements as well, depending on what resources you have available to you. And that's the kidney transplant package in terms of the competencies. And then what we've also done is we've created some downloadable resources which we hope will be useful for transplant centres to use. So we're trying to make it easy for centres so they don't have to reinvent the wheel. So these are downloadable, printable if necessary, resources that can be used to either present to patients or to use as an aid for staff to deliver patient education around enhanced recovery principles. There's a journal, a shared care plan, again similar to the one that we used in Newcastle. There's charts that patients can record, how many walks they've managed that day, how long they've sat in their chair, etc., so they can feel a part of their own recovery. So we hope that this will be helpful. And this is what we're trying to achieve, and we're trying to achieve this across, as I say, all the organ groups. Just to give you an idea, this is the kind of structure of NHSBT. You heard Derek Manus's name mentioned a bit earlier, so he's the medical director of NHSBT, and it was really his dream to transfer this across the UK. He was with us in the programme and led our ERAS programme in Newcastle, and so he wanted to see this replicated across the UK. Lisa Benap is the associate medical director, and she leads overall on this programme, with me supporting her as a subject matter expert. And under that we have a multidisciplinary steering group, and that's made up of people from across the UK, of a variety of disciplines across the MDT, and then we have our work streams, and you can see in green there we've now published our adult kidney transplant recipient work stream on the website, and we're currently working on the adult liver transplant recipient work stream and the living kidney donor work stream as well, and we have an ongoing evaluation and measurement work stream to support that as well. And then we're also in talks with people from the pancreas transplant community and the lung transplant community, and we're in the process of setting up work streams for those, and also talking to the paediatric kidney transplant community as well. So it's been an organic process, and we started out with kidneys, and then what we've done is we've let the community come to us, and we found that with the success of the kidney programme that people have come to us from other areas of transplant and said, actually, can we get involved in pancreas, lung transplantation, we want to get involved. And so that's been a really good way to evolve the programme, really. And as I said, it includes people from across the UK, from different disciplines. We've got patient representation there, we've got donor representation, we have surgeons, medics, physios, nurses, all of the disciplines. So it's a real multidisciplinary approach, and we hope that we will take some of the work away from centres and make this replicable and useful for transplant centres in the future. I'd just like to finally thank everybody at Newcastle for the work we did there, and everybody on the team at NHSBT as well. And thank you for your time.
Thank you for completing your presentations on time, rather before time. So that has saved us some time, and the floor is open for a few questions if you have. Yeah, Dr. Pokar.
Very nice and useful talk, Carrie. You said you are trying to remove the catheters and drains in day 2, day 3, right? Mm-hmm. That means our normal practice, which I learned from Newcastle, was you almost all remove the catheters and by day 5 and send the patient home. That is the time to discharge, minimum time. Mm. If we are removing the drains and catheters in day 2 or day 3, if the patient is doing fine otherwise, so are you thinking to discharge the patient in day 2 or 3 post-op? Or
Yeah, I mean, so our target day is actually day 5. We've certainly discharged patients on day 3. Obviously, there are other variables, and what we can't do is remove delayed graft function and things like that, and we have limited resources in terms of it would be nice if we could send patients home that are well and still, for example, receiving dialysis, but we don't have great ways of doing that at the moment. So actually, that's one of the things that sometimes keeps patients in. But you can see our mean length of stay is 6 days, but we certainly have had patients go home on day 3.
Ma'am, the drain should not be a deterrent for ERAS, I believe. They can go home with the drain and then...
They could, yeah. Certainly the drain doesn't limit. Very occasionally we have a patient who goes home with a drain if necessary, but actually in the majority of cases it's other factors that keeps patients in. We don't keep patients in because they have a drain. So yeah, you're right.
Hi, Carrie. I have a question. So I think ERAS didn't happen overnight. It probably took a long time to coordinate all those puzzles and bring that picture. So who is coordinating in your hospital for application of the ERAS
for the
protocol?
program? Yeah. So when I was in Newcastle and working there, that was my role. So I was the lead nurse for enhanced recovery and transplantation. So I was coordinating the program, linking everybody together. And then what we did was we tried to have a light touch approach, in that I couldn't be on every single ward round. I couldn't be there when every single patient came in the middle of the night. So we tried to have robust resources in terms of documentation. So we had really clear protocols, and we created an aid memoir. I sort of briefly showed it, but you couldn't really see it on the screen. But like a flow chart for nursing teams particularly, so that people knew what the targets were, what they should be aiming for, what the criteria was, so that even if I wasn't there, hopefully it could run. But certainly having me there, or having a person there to coordinate definitely benefited and made it easier, but we tried to make it run itself, if you like.
And when did you think, or the team thought that it is making some progress in the patient's outcome? Like few of the points that you think were more important than the others to bring changes in patient's outcome?
Sorry, I'm not quite sure I understand the question.
Like all those things didn't happen at the same time, right?
Well, we implemented the program at the same time. Yeah, everything was a one program, so all those changes happened at the same time.
Okay, like removing drain or putting your tap catheters. So it happened one at a time. So when did you think, or the team thought, that this step is making a significant change in patient's outcome? Is there something like that?
We didn't do it one step at a time. We did everything at the same time. So the first patient we did through an ERAS pathway, had the catheter removed earlier, had a tap catheter, had everything. So you're right, it's very difficult to take out one specific element and accurately say, this is the thing that changed it. I would argue in my experience that it is the package that makes it work, and it's not one set thing, and it's actually a combination of those things that makes it work and makes it better, and it's the preparation and the experience of the patient as well. But there isn't one thing that you could take out of the data, although length of stay is an easy thing to measure, and that's something you can see that shows that it all works, but I can't say that it's just because of this or just because of that, but I can tell you that tap catheters were the reason that we were able to reduce the opiates and the reason that the nausea reduced, and but I can't say which one was more important than the other.
Okay, thank you. Thank you.
Yes. Any question?
I think you're absolutely right in that you can't make you can't pinpoint the success of the program to one thing, but once you start an enhanced recovery program, and this is for people who are wanting to start something like this at a very early stage, you start pushing the boundaries slowly. You create the package, and you start thinking, well, okay, I can take catheters out on day 3 rather than day 5. And then you say, I can take the catheters out on day 2. And we actually, at the very beginning, wanted to take the catheters out on day 1, but there was a lot of resistance to that at the start. So you start slow, just like with everything else I think we've been talking about in the conference. You start slow, you gain the confidence, and you create the culture, and then you slowly push the boundaries even more. So with drains, for example, we don't look at the volume of the drain so much anymore. On day 2, if the drain still has more than 100 mils in it, but it's not creatinine rich, we'll take the catheters out.
Yeah.
So yeah, you just keep pushing the boundaries, I think, with time, but always start slow and start small.
Yeah, it's a really good point, because it's a culture change is one of the biggest things of implementing something like this. And we did have resistance at the start, and we had, surgeons that said, I'm not taking the catheter out that early, I don't want to do that, this is, but over time, and once we were doing it, and we could show the results and show we didn't have any urine leaks, for example, we gained confidence, and then we pushed the boundaries. We didn't necessarily go, as Eamon said, for the goal that we wanted, which was day 1, because we knew we wouldn't get it, and if we had one complication, that would stop the programme, whereas if we just edged a little bit, got some confidence, edged it a little bit more, and the whole thing kind of encourages that ethos of just pushing the boundaries and moving it forward. So yeah.
Thank you, Carrie, for your informative presentation. So I wanted to ask 2 things. At first, how you guys convinced your team to implement the ERAS, and what were the practical challenges while implementing this?
Thank you. Yeah, so a little like I was just saying, I think because it's a culture change, it's getting people on board, and we had to make sure we had the right people in the room, so we had to make sure we had representation from all of the stakeholders, all of the multidisciplinary team, and we recognised quite early on the people who were perhaps not the biggest fans and weren't wanting to come with us, and we maybe focused on them a little bit more and tried to show them the evidence that was out there, talked to them a bit more about what we were trying to achieve, and tried to sort of bring them in even if they weren't wanting to. And I think it's that nurturing and that kind of inclusion, because if you're making change, then if you exclude people, they don't want to be, but if you try and include them and make them part of the decision making and feel empowered, they're more likely to come along with you. So we tried that approach really, and I think it was fairly successful. And certainly even Professor Talbot, who you all know really well, at the start of this, he wasn't a fan of ERAS. He thought it was just a bit of a gimmick. But actually, he was great, and he sort of changed his mind over the course of the programme. And he will say to you now, yeah, I just wasn't really sure to start with, thought it was a bit, I'm not quite sure. But actually, now he will say, I'm on board, and he will take drains out earlier, and he adheres to the programme, and he thinks it works well. So, he will be the first to admit that, sometimes you do just need to come along with something. And so we tried to just bring people along. And in terms of practical obstacles, I think it was just more people than anything, to be honest. It was changing people's opinions and changing people's... it's a different mindset to, rather than that kind of apathy of, well, leave the drain, take it out, whatever, it doesn't make much difference, just talk about it tomorrow, I'm busy, but actually if you're that patient in that bed with a really uncomfortable draining, that means you can't sleep very well, and it's, amongst other things, it's if you can get it out earlier and you can progress that patient and make them feel more comfortable, and then they're taking less painkillers, it's all that kind of thing, it all has an add-on effect, I think.
Thank you.
May I ask one question?
Yeah, please. Last
I
question.
think we're quite short in time, so if we just keep it brief. That's all I was going to say. Last question, just keep it brief.
Thank you. If you want to convince me, please tell me in how many patients the urinary catheter was giving back. Because you take out the catheter at the 3rd day, and you have the different kind of urinary bladders. You have the different quality of the urinary bladder. You have sometimes the anastomosis is really very difficult. And the last question: do you use in every patient the double G catheter to decompress the anastomosis between the ureter and the urinary bladder?
Oh, stent, stent. So to answer your first question, so you're right, and not like we've heard in other talks, not all patients are the same, and so some patients have very small bladders, some patients have difficult anastomoses, and so not one size fits all, but all patients ERAS should be applied to all patients as to whether it fits, and the rest of the, elements can still be applied, but with certain patients there are criteria. So if the surgeon, and everything is, at the surgeon's request, if the surgeon carries out the operation and thinks, okay, we said we were going to take this catheter out on day 2, but I'm not happy with that because of the difficulties of the anastomosis, then we would honour that. So there is you can scale it and you can change it slightly. And if there's a certain patient that doesn't meet the criteria, that has some, issues that means you want the catheter to stay in longer, then that's okay. And we did that for patients. But that didn't mean that those patients were no longer ERAS patients, because potentially you could still take the drain out, they could still have the education, etc., etc. And yes, we do use stents with all of our patients, but we also kept them in for quite a while, and we know there's evidence, which actually Emily published, about stent removal and how it's safe to remove stents early, and so we did also change to removing stents earlier as well.
Okay, thank you very much. I'm very glad that sometimes we are listening for the surgeons.
Thank you, Carrie. But the chairperson has the privilege to ask you one question.
Okay.
The
of course.
two patients are never the same, and this is very difficult surgery, very important surgery, especially kidney transplant I'm talking about.
Yeah.
So if a patient is having catheter drain which cannot be removed on the second day or third day,
yeah,
and there may be some urine collections inside, and usually TAC level is sent on second or third day. So after that, we usually stabilize. We feel that patient is stabilized, and we send the patient home. But if your ERAS formula is followed in all the patients, is it in all the patients, or do you individualize the patients depending on the conditions post-operative?
In terms of follow-up and monitoring?
Yeah, and if some patient is to be sent home with catheter, with drain.
Drain in, yeah.
So is the patient kept inside, nearby? Because in our circumstances, we have very difficult terrains. We cannot send the patient far away from the hospitals.
Yeah, and it can be challenging, you're right. And I mean, even in Newcastle, so we have people who are from the transplanting centre who live a mile away, and we have people from the borders of Scotland who live hours away. So it depends on the patient, and we have to, all the time, when anything we do, we have to think about the individual. And so we look at the follow-up at the time, and that's part of the ERAS programme, is making sure that the follow-up is organised well and is the right standard that patient needs. So if they have to go home and they have a drain in, we make sure that we have some sort of way of monitoring them and monitoring that drain. If the patient is able to do it themselves and be taught how to look after it, how to empty it, and they can be seen in their referral centre, that's something we sometimes do. If they choose to come all the way back to Newcastle for review, they can do that. If they have learning difficulties and other complicated factors, we might keep them in. It is individual, you're right.
Thank you.
Okay. Thank you very much. Thanks for stimulating such a great discussion, Carrie. So I think we're going to be closing this session now.